1 in 13 Black people worldwide carries 2 copies of a gene that multiplies their risk of kidney failure by 17 times. And most of them have no idea it exists. You have probably never heard your doctor mention it. You might have family members on dialysis right now, and nobody ever explained why their kidneys failed so young. Not high blood pressure alone, not diabetes alone. Something deeper, something written into the code before they were born. The gene is called APOL1, apolipoprotein L1, and if you carry 2 high-risk versions of this gene, your kidneys are working against odds that most nephrologists will never tell you about in a standard appointment. Here is what that means for your body. APOL1 is a gene that everyone has. It sits on chromosome 22, and it codes for a protein that protects you against a parasitic infection called trypanosomiasis, sleeping sickness. The same parasite that has killed millions of people across sub-Saharan Africa for thousands of years. Your ancestors developed 2 variants of this gene that kill that parasite more effectively than the standard version. Those variants are called G1 and G2, and they are found almost exclusively in people of African descent. If you trace your ancestry back to West Africa, Central Africa, or parts of East Africa, there is a significant chance you carry at least one of these variants. They saved lives. They still do, in regions where sleeping sickness is endemic. But those same protective variants come with a trade-off. If you inherit 2 copies, one from each parent, your kidneys pay the price. The protein those variants produce damages the filtration units inside your kidneys, the tiny structures called podocytes. They are the cells that keep your blood clean and keep waste moving out of your body. When APOL1 high-risk variants are active, those podocytes start to break down, slowly at first, then faster if you add other stressors to the system: high blood pressure, diabetes, viral infections like HIV, even severe dehydration or certain medications. Your kidneys do not announce this damage with pain. There is no alarm that goes off when a podocyte dies. You feel fine, you go to work, you take care of your family, and your filtration rate drops year after year until one day a routine blood test comes back and your doctor says your creatinine is elevated. Your kidneys are not clearing waste the way they should, and by the time you hear that, the damage is often already advanced. Now I know what some of you are thinking. My doctor told me my kidney problems are because of my blood pressure, and that is true. High blood pressure does damage kidneys. But here is the part nobody explained. If you carry 2 APOL1 high-risk variants, your kidneys are far more vulnerable to that damage than someone without those variants. The same level of blood pressure that might take 30 years to cause kidney disease in someone else can cause it in you in 10. That is not your fault. That is biology. And you deserve to know that from the beginning. Let me say that again. You deserve to know that from the beginning. Approximately 13% of Black people worldwide carry 2 copies of these high-risk APOL1 variants. 1 in 13. If you are in a room with 12 other Black adults, statistically, one of you has this genetic combination. And the vast majority of people who carry it have never been tested, never been told, never been given the information that could have changed how they managed their health for the past 20 years. The research that identified these variants was published in 2010. A team led by Dr. David Friedman and Dr. Martin Pollack at Beth Israel Deaconess Medical Center in Boston analyzed the genomes of thousands of people with kidney disease and found that these 2 APOL1 variants were the primary genetic driver of the massive disparity in kidney failure rates between Black and white populations. Before that study, doctors knew that Black patients had kidney disease at higher rates. They attributed it entirely to social factors: poverty, diet, access to care, stress, and all of those things matter. But they could not explain why 2 people with the same blood pressure, the same income, the same access to healthcare could have completely different kidney outcomes. The answer was in the genome, and it had been there the entire time. Here is what the numbers actually show. If you carry 0 APOL1 high-risk variants, your lifetime risk of kidney failure is low. If you carry 1 copy, your risk is slightly elevated but still manageable. If you carry 2 copies, your risk jumps to somewhere between 15 and 29 times higher than someone with 0 copies, depending on what other health conditions you have. 29 times. Read that back, right now. And this is not evenly distributed across the African diaspora. The G1 and G2 variants are most common in people whose ancestors came from regions where sleeping sickness was historically prevalent. West Africa especially, Nigeria, Ghana, Cameroon, Senegal. If your family history traces back to those regions, your chance of carrying at least one variant is close to 40%. Your chance of carrying two is higher than the global average of 13%. If your ancestry includes the Caribbean, the southern United States, or parts of Brazil, the same risk applies. The genetics traveled with the people. The slave trade did not erase this. It concentrated it in certain populations. And then the medical system spent the next 400 years ignoring it. You might be saying, Marcus, that sounds like conspiracy talk. And I hear you, but let me be very clear. This is not a conspiracy. This is a research gap, a structural failure. The APOL1 variants were not discovered until 2010 because the vast majority of genetic research before that year was done on people of European descent. White populations do not carry these variants at any meaningful frequency. So the studies that built our entire understanding of kidney disease simply did not see them. That is not malice. That is exclusion. And the effect is the same. You have been living with a genetic risk factor that increases your chance of kidney failure by double digits, and the medical system did not prioritize finding it until 14 years ago. Some of your family members went on dialysis before this information even existed in the scientific literature. Think about what that means for your body. Here is what happens inside your kidneys when APOL1 high-risk variants are present. Your podocytes, the cells that filter your blood, produce a version of the APOL1 protein that is slightly more toxic to the cell itself. Under normal conditions, your body can manage that toxicity. The protein does its job killing parasites and then gets broken down and cleared. But when your kidneys are under stress, when your blood pressure is elevated for years, when you have untreated diabetes, when you get a severe infection, that protein starts to accumulate. It triggers a process called apoptosis, programmed cell death. One podocyte dies, then another, and your kidney tries to compensate by working the remaining cells harder. But there is a limit to how much compensation is possible. Once you lose a certain percentage of podocytes, your filtration rate starts to drop. Waste builds up in your bloodstream. Your body starts retaining fluid. Your blood pressure climbs even higher because your kidneys can no longer regulate it properly. And the cycle accelerates. By the time you feel symptoms, you might have lost 50% of your kidney function. And once you are below 30%, you are in stage 3 chronic kidney disease. Once you are below 15%, you are in kidney failure. And the only options left are dialysis or transplant. That is the part nobody told you. Let me tell you about the kind of patient I used to see before APOL1 testing became available. A woman in her early 40s, no significant medical history, maybe mild hypertension that her primary care doctor was treating with a single medication. She felt fine. She worked full-time. She raised her kids. And then one day, she went in for a routine physical, and her creatinine was 4.2. Her eGFR was 18. Stage 4 chronic kidney disease, almost in failure. She sat in my office, and the first thing she said was not a question about treatment options. It was not about dialysis or transplant. She looked at me and said, "How do I tell my daughter this is genetic?" She did not ask me how this happened to her. She asked me if it was going to happen to her child, and I had to tell her I did not know. Her blood pressure had been controlled. She was not diabetic. She did not have lupus or any autoimmune disease. There was no obvious cause. And she looked at me like I had just told her the rules of the universe did not apply anymore. She said, "So my kidneys just failed for no reason, and my daughter might be next?" I said, "Not for no reason. We just do not know the reason yet." 3 years later, the APOL1 research came out, and I tested her. 2 copies, G1 and G2. She had been walking around with a 17-fold increased risk of kidney failure her entire adult life, and nobody knew to look for it. Not her, not me, not the system. She is on dialysis now, 3 times a week, 4 hours per session, waiting for a transplant that might not come for years. And every time I see her name on my schedule, I think about what we could have done differently if we had known 10 years earlier. If we had tested her at 30, if we had been more aggressive with her blood pressure control, if we had told her to avoid certain medications, if we had monitored her kidney function every single year instead of every 5. Her daughter tested positive too, 2 copies. But now we know. And that daughter is 24 years old with perfect kidney function because we are managing her health like someone with a genetic vulnerability, not like someone with average risk. That is not an accident. That is information being used the way it should have been used from the beginning. Now here is where the science gets even more specific. The ApoL1 protein does not just sit quietly in your podocytes waiting to cause damage. It interacts with other biological systems in ways researchers are still mapping. When you have an infection, especially a viral infection, your immune system ramps up production of interferons. Those are signaling molecules that tell your cells to fight harder. And one of the things interferon does is increase ApoL1 expression. That means your kidneys start producing more of this protein right when your body is already under stress. If you carry the high-risk variants, that surge in protein production can trigger acute kidney injury. Not over years, over weeks. This is why Black patients with HIV used to develop a condition called HIV-associated nephropathy at rates far higher than white patients with the same viral load and the same access to treatment. It was not just the virus. It was the virus plus the ApoL1 variants plus the immune response. All 3 working together to destroy podocytes faster than the kidney could replace them. And here is what makes this even more urgent. COVID-19 does the same thing. During the pandemic, doctors noticed that Black patients were developing acute kidney injury at higher rates than other groups, even after controlling for diabetes and hypertension. Initial reports attributed it to underlying health disparities, and that was part of it. But ApoL1 was the other part. The virus triggered interferon production. Interferon triggered ApoL1 expression, and patients with 2 high-risk variants saw their kidney function drop in a matter of days. Some of them recovered. Some of them did not. And the ones who did not recover were disproportionately people who had no idea they were genetically vulnerable in the first place. You cannot change whether you were exposed to COVID, but you can know your ApoL1 status so that the next time you get a serious infection, you and your doctor are prepared to monitor your kidneys closely. That is what knowledge does. It does not eliminate risk. It gives you a fighting chance to manage it. Now let me walk you through what you need to do. And I need you to hear this as if I am sitting across from you in an exam room, because that is exactly how I would say this to a patient. Step 1. Ask your doctor about ApoL1 genetic testing. This is a simple blood test. It checks whether you carry 0, 1, or 2 copies of the G1 and G2 variants. Some insurance companies cover it if you have a family history of kidney disease. Some do not. If your insurance will not pay, the test costs between $100 and $300 out of pocket, depending on the lab. That is expensive, I know that. But it is also information that could add 10 years to your life. If you test positive for 2 copies, that does not mean you will definitely develop kidney disease. It means your risk is significantly higher, and you need to be far more aggressive about protecting your kidneys than someone without those variants. And if your doctor is not familiar with ApoL1, do not let that stop you. Print the research. Bring it to your appointment. You are allowed to educate your physician. You are allowed to ask for a referral to a nephrologist who specializes in genetic kidney disease. You are paying for that appointment. You get to ask for what you need. Step 2. If you carry 2 high-risk variants, monitor your kidney function every single year. Not every 5 years, every year. That means a basic metabolic panel that checks your creatinine and your estimated glomerular filtration rate, your eGFR. That number tells you how well your kidneys are filtering waste. A normal eGFR is above 90. If yours is between 60 and 90, you are in the early stages of reduced function. You need closer monitoring. If yours is below 60, you need to see a nephrologist. Not in 6 months. Now. And here is the part most primary care doctors will not tell you. The eGFR calculation that labs use was updated in 2021 to remove race-based correction factors. For decades, the formula assumed that Black patients had higher muscle mass and therefore higher baseline creatinine levels. So it artificially inflated eGFR numbers for Black patients. which means thousands of people were told their kidney function was fine when it was actually declining. If you had labs done before 2021, ask your doctor to recalculate your eGFR using the new race-free equation. Your real number might be lower than what you were told. And if it is, that changes your treatment plan. Step 3. Control your blood pressure like your kidneys depend on it, because they do. If you carry 2 ApoL1 variants, your target blood pressure should be lower than the standard recommendation. Some nephrologists now recommend keeping it below 120/70, not 130/80. Talk to your doctor about whether that target is right for you. And if you are on blood pressure medication, make sure you are taking it consistently. I have seen patients whose kidney function stayed stable for years because their pressure was controlled, and then they missed doses for 2 weeks and their creatinine jumped half a point. Your kidneys do not forgive inconsistency. Step 4. If you have diabetes, manage it aggressively. High blood sugar damages the small blood vessels in your kidneys. If you already have APOL1-related vulnerability, uncontrolled diabetes will accelerate the damage by years. Your hemoglobin A1C should be below 7, ideally below 6.5. Check it every 3 months. And if your doctor tells you your A1C is acceptable at 8 or 8.5, push back. That might be acceptable for someone without genetic risk. It is not acceptable for you. Step 5. Avoid nephrotoxic medications when possible. That means non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, aspirin in high doses. These drugs are hard on kidneys even in people without genetic risk factors. If you carry 2 APOL1 variants and you take ibuprofen regularly for joint pain or headaches, you are directly damaging the organ you are trying to protect. Talk to your doctor about safer alternatives for pain management. Acetaminophen is easier on the kidneys. Physical therapy for chronic pain. Topical creams. Anything that does not force your kidneys to process drugs that constrict blood flow to the filtration units. And if you ever need to take ibuprofen for a short period, make sure you are well hydrated before and after. Dehydration plus NSAIDs is one of the fastest ways to trigger acute kidney injury in someone with ApoL1 variants. Step 6. Stay hydrated. Dehydration forces your kidneys to work harder. When they are already vulnerable, that stress accelerates podocyte loss. Drink water consistently throughout the day, not just when you feel thirsty. By the time you feel thirsty, you are already behind. And if you work outside in hot weather, if you exercise intensely, if you travel to a climate that is hotter than what you are used to, double your water intake. Your kidneys are filtering your blood 24 hours a day. They need fluid to do that job safely. Step 7. If you have a family history of kidney disease, especially if multiple relatives needed dialysis before age 60, assume you might carry the variants until testing proves otherwise. Do not wait for symptoms. Symptoms come late. By the time your back hurts or your ankles swell or you feel tired all the time, the damage is already done. Kidney disease is called a silent killer for a reason. It does not hurt until it is too late to reverse. Step 8. Talk to your family. If you test positive for 2 APOL1 variants, your siblings have a 25% chance of also carrying 2 copies. Your children have a 50% chance of carrying at least 1 copy. This is genetic information that affects the entire family tree. You are not required to share it, but if you do, you might save someone else from going through what you have been through. I have had patients bring their entire extended family in for testing after they found out they carried 2 variants. Siblings, cousins, adult children, and in one case, a grandmother who had been on the transplant list for 3 years finally understood why her kidneys had failed when she was only 52. It was not stress. It was not bad luck. It was APOL1. And her granddaughter, who was 19 at the time, tested positive too. That granddaughter is now 30. Her kidney function is perfect because she knows, and she is managing her health accordingly. That is generational protection. That is information being passed down the way it should be. Now I want to be very clear about something. The existence of ApoL1 variants does not mean that social and environmental factors do not matter. They absolutely matter. Poverty increases stress. Stress increases blood pressure. Lack of access to healthy food makes diabetes harder to control. Environmental toxins damage kidneys. Discrimination in healthcare leads to undertreatment and delayed diagnosis. All of that is real. All of that contributes to the kidney disease disparity. But APOL1 explains why those social factors hit Black communities harder. It explains why two people with the same level of poverty, the same diet, the same stress, can have completely different kidney outcomes. One carries the variance, one does not. And that biological difference compounds every social disadvantage. This is not about blaming genetics and ignoring systemic racism. This is about understanding that both things are true at the same time. The system failed you, and your biology made you more vulnerable to that failure. Fixing the system matters, but while we are waiting for the system to change, you need to protect yourself with the information we have right now. And here is the part that gives me hope. Research on APOL1 is exploding. Scientists are developing drugs that specifically target the toxic effects of the high-risk variants. Medications that could protect podocytes even in people who carry two copies. Some of these drugs are already in clinical trials. They are not available yet, but they are coming. There is also research into gene therapy, techniques that could theoretically turn off the high-risk variants or replace them with protective versions. That science is years away from clinical use, maybe decades, but it exists. People are working on it. And in the meantime, there are nephrologists all over the world who now screen their Black patients for APOL1 as part of routine kidney care. That was not happening 15 years ago. It is happening now, slowly, inconsistently, but it is happening. The gap is closing. But it is closing because patients like you are asking the questions, demanding the tests, refusing to accept vague answers when their health is on the line. You do not have to wait for your doctor to bring this up. You can bring it up yourself. If this information is new to you, I want you to do something for me. Leave a comment below and tell me, have you ever had a doctor talk to you about your genetic risk for kidney disease? Have you been tested for APOL1? And if you have family members who have been on dialysis, did anyone ever explain why? I read every single comment, and I want to know what your experience has been, because the more we talk about this openly, the harder it becomes for the system to keep ignoring it. And if this video gave you information you needed, hit that like button and subscribe to this channel, because I am going to keep bringing you the research they are not telling you about in your 10-minute appointments. The science that applies specifically to your body, the truth you deserve to hear. Here is what I need you to understand. The APOL1 story is not just about genetics. It is about what happens when an entire population gets left out of the research that determines how medicine is practiced. It is about the cost of that exclusion, measured in dialysis machines and transplant waiting lists, and families watching their loved ones deteriorate in ways that could have been prevented. But it is also about power, because now you know. And knowledge is the first step toward protection. You cannot control whether you carry the variants, but you can control what you do with that information. You can get tested. You can monitor your kidney function. You can push your doctor to take your family history seriously. You can make decisions today that your kidneys will thank you for 10 years from now. You are not a statistic. You are not 1 in 13. You are a person with a body that has been carrying information your ancestors wrote into your DNA to keep you alive. And some of that information comes with trade-offs. That is not weakness. That is survival. Your job now is to survive the next chapter too. I became a doctor because I got tired of watching people I loved suffer from diseases that should have been caught earlier, treated differently, explained better. And the more I learned about health disparities, the more I realized that the gaps were not random. They were structural, built into a system that was never designed with us in mind. APOL1 is one example. There are dozens more. Genetic variants that affect drug metabolism, differences in how inflammation presents, risk factors that only show up when you disaggregate the data by ancestry. All of it sitting in the research literature. All of it ignored in standard clinical practice. But you do not have to wait for the system to catch up. You can take this information and use it. You can be the person in your family who breaks the cycle, who gets tested, who asks the right questions, who refuses to accept vague answers when your health is on the line. Your kidneys are not failing for no reason. Your family history is not just bad luck. There is biology here. There is genetics. There is a clear explanation. And now that you know it exists, you get to decide what comes next. Protect your kidneys. Get tested. Share this video with someone who needs to hear it. And remember, the best time to start protecting your kidney function was 20 years ago. The second best time is right now. Before you go, this video is educational content, not personal medical advice. If anything I said today concerns you about your kidney health or your genetic risk, take that information to your doctor. Have that conversation with them. Do not stop or change any medication without talking to your physician first. This channel exists to give you the research they are not always sharing in your appointments. But it does not replace medical care. It supports it. Take care of yourself, and I will see you in the next video.